Great, so welcome everyone and thanks for joining. This is the fourth in a series of networking events that we at Loft Digital have been organising in partnership with Health Foundry. Our other events so far have all been in person, but due to the current COVID situation, obviously we're hosting this one online. So we do hope for the next event to be back in having an event in person, but it's nice to be able to include people who may not be able to get to London so easily. So that's one benefit of being online. We started running these events because we wanted to sort of create a little community of entrepreneurs and other people who are interested in health tech, so that we can all exchange ideas and talk about topics that are of interest. We at Loft, some of us are self-confessed geeks. Nick won't mind me saying that. So we were interested in meeting other people who were interested in talking about health systems and health data. I'll let Nick, I'll hand over to Will in a moment and Nick to do introductions to Health Foundry and Loft, but I just want to say thank you for coming. And the next event, I'll talk a bit more about that at the end, but we'll be running a poll towards the end of this event so that we can decide on what topic would be most of interest for the next of these events, which will be in March.
Brilliant. Thanks, Helen. And just to introduce myself, I'm Will Nicholson. I'm the Programs and Partnerships Lead at the Health Foundry. For those that don't know, Health Foundry is a digital health community based in Waterloo in central London. We have both the physical space where you can co-work along with others, hold meetings, run different types of events and networks, but as Helen was mentioning, we're really interested in probably two key things. One is about bringing together a community of people who are interested in making a difference through improving people's health and well-being through partnership, through working together. And we're really passionate about making connections and connecting with others who share that similar interest. And it's been fantastic working with Loft, who are both a member of the Health Foundry, but also share that interest in community and bringing people together. And I think what we're doing today is a great example of that, where we're working as combining our interests in health tech more widely, but also Loft's particular interest in data. And we've been running a series of these events in order to just facilitate more connections in this area. And we're really excited by today. The format for today, because we want to keep this as light touch as possible, to give everyone a chance to meet as many different people who sort of are working in this space and have that shared interest in data, and also to raise just some of the successes and challenges that we all might be facing. We've come up with a very short sort of light touch introductory format, where we're going to ask a number of speakers to speak for 5 minutes each. Very short time frame. I'm not normally very officious with things, but today I'm going to be holding the speakers to their 5 minutes, just to give a brief introduction to who they are, what makes them tick, and their interest in data. We'll then have a chance for some Q&A afterwards. Feel free, as people are talking, to post any questions that you have in the chat, and we'll direct them to either to all the speakers or to a particular speaker. Just make it as clear as possible. We are recording it. We're just recording the speakers, so no one else will be on camera. And we can share sort of information that people share in the chat afterwards, if you're happy to put your contact details or links to any work that you have. So without further ado, I'm going to pass over to our first person who's going to talk tonight, which is Nick, the founder of Loft Digital. Over to you, Nick.
Thank you, Will. So Will asked me to sort of give a little intro to myself and talk a little bit about what makes me tick and why did I get interested in data. So I've been giving some thoughts about that this afternoon. I'm, as Helen said, I'm a techie through and through. I've been programming things ever since I was a boy. It's in my blood. My dad writes software for spacecraft and has done for a long time. So I got an interest in computers and tech from a really early age, certainly age of 5, 6. I was mucking around with things. And I've always been interested in data and systems and logic. Certainly when I was a teenager, I might spend, I'm sorry to say, I might spend an evening designing a database or a system when my buddies were out playing football. So that's just me and what I was like. And I also have a huge passion, unusually perhaps for a techie, for people, and for connecting people, and for communication, and for sharing. And so those sort of things working together have really got me interested in data and information and technology, and what can we do with it. So, you know, obviously the internet, when I discovered it in the mid-90s, I'm 46 now, by the way, so that was when I was around about 1990, was an absolute revelation. My God, you know, suddenly I can access the whole world. I can talk to people, I can put my ideas or inventions online, I can distribute them, I can look at other people's stuff. It was a revelation. I very quickly got into programming and developing things online and on the internet that I could share with other people. I'm a self-taught programmer, and I started developing web applications then. Web applications are notable by the fact that you have many users using them at the same time. And so you're always working with data, you're always working with passing data between people, you're managing the state of that data, and as they get more and more complex and scale up to thousands or even millions of users, you're dealing with really complex data moving around very quickly, a lot of people. So that was a big area of interest. And where I really sort of coalesced about my sort of slight fascination or obsession was when I came across a book that was published in 2009 called Information is Beautiful. And Information is Beautiful had all these stunning, I don't know if anybody knows it, all these absolutely stunning charts and graphs developed by a really great designer who understood how to take data and information and make it visually and creatively really interesting and meaningful to people. So I would really recommend taking a look at that book. It would seem a bit dated now, our concept of infographics and how we can communicate information has really moved on since then, but it's still full of brilliant ideas. So that was terrifically exciting, and that sort of led me on a journey from there to start to think about how can we actually take data. A lot of people think data, God, that's really boring, but actually I think it's exciting, and I think when we can bring it to life for people, and when we can use design to make it meaningful to people, and when we can use data to enable people to interact and share things and do things that they couldn't do before, together, that's really exciting, and people get really obsessed with it. And suddenly you find that where once upon a time computers were thought to be the domain of geeks, suddenly everybody's on their phone all the time and really struggle to put it down now. So I think we can see how exciting that is. My journey into the sort of world of health data began a little bit later, about 5 or 6 years ago, when my eldest boy was born. And that was my kind of first major experience of the UK health system. And I learned very quickly there that the technology and the use of data within Whittington Hospital in North London was far behind what I had at home. And I thought this was really unfair and not a good situation at all. So my company, Loft Digital, which I've been running since 2007, I've made a decision that one area that I really wanted to focus on was health tech and the opportunity there, and how we could use our skills to help bring new exciting technology in that space. And data, of course, is really exciting in health, isn't it? It's about our bodies. It's really sensitive, it's personal, it's biological, it's really complicated, and there's loads of difficult stuff to work with. So that's good fun for techies.
Brilliant, Nick. I was about to come in and say that's your time, but I think you've done a really lovely introduction there. Thanks so much for sharing. And without further ado, I'm going to pass on to Mari from Doctors in Distress.
Well, I think Aileen's going to kick us off, and then I'll come in straight after.
Perfect.
Yeah. Hi, everyone. My name's Aileen. I'm here with my colleague Mari. We work for the charity Doctors in Distress. We're a relatively new charity. We were just formed in 2018 after the tragic death of a consultant cardiologist named Jagdeep Sidhu. The charity was formed by his brother, and we very much support the mental well-being of healthcare workers in the UK. The main way that we do this is to provide peer support groups to different roles and departments within the NHS. Some examples of groups that we've run in the past are for ITU staff, for nurses and doctors with long COVID, and also paramedics. We run a creative project with a focus on restoration and reflection. It's a multifaceted project. We have kind of different elements to it, which include expressive writing groups, a photography exhibition, and a play that's being written for us. Yeah, we are very much a preventative charity. So we don't do counselling or therapy. We want to come in kind of to support and before healthcare workers might need those interventions. Another element that we do is we host leadership webinars and webinars for medical students or junior doctors to kind of break down the stigma that is present within the healthcare profession around the mental well-being of the healthcare workers. I'm going to pass over to Mari to talk a little bit about data and how we use it and collect it.
Hi everyone. I don't think we really thought a lot about data when it was first established, when the charity was first established. Although in our aims and ambitions, at the very top, in a bid to understand how serious suicides in the medical workforce are, we do say, every 3 weeks a doctor dies by suicide. So we have used data straight off the bat. The support groups that we run, we are very, very, what's important to us is that the participants who take part know that it's a confidential and safe space. And because we're in the prevention space, we only ask for qualitative data, and that's the data that we evaluate at the end of each of our programs. However, we really use data from the health and medical workforce as part of our proposals, and definitely for people to understand what we do and why we do it. So we know that the qualitative data that we have and that we collect is important to us and to our board to understand and measure the success of what we do. But the data that other organisations collect is what we use to inform those outside of our organisation in our proposals, parliamentary papers and papers that go to press, because that is what will help us get the message out and what people can understand. So it might be seen as kind of like on the light side of data, because it is qualitative and not quantitative. But yeah, that's where we are with data, and perhaps where we struggle is our sources. We have sources from practitioner health, who look after the health of all the doctors and medical workforce in the UK from a mental health perspective. But we would like more exposure to data and factual data that's relevant to the groups that we run. Yeah.
Brilliant. Thanks so much. I think the work that you're doing, is so important, so needed at the moment. And I just sort of mentioned to anyone that's got questions or any thoughts, please post them in the chat, because I think anyone that can support the work that you're doing, and any of the founders here actually with the work that they're doing, would be hugely appreciated. So yeah, please post that in the chat. So I'm going to bring in our next speaker now, Lucy from the Gut Feeling, who's actually sitting next to me. So I'm going to hand over to her.
Hi everyone, I'm Lucy. I read the invite for this evening too quickly and thought it was in person. So I am here in person. I am founder of the Gut Feeling. We're fundraising at the moment, so it's very, very hectic, and clearly I need to spend more attention to reading emails properly. So I'm founder of The Gut Feeling, and we are focused right now on building the world's largest digestive health database and leveraging it for good. So a bit on me. Before I started The Gut Feeling 2 years ago, I spent 4 to 5 years working in startups, in management consultancy, specializing in technology, innovation and healthcare, a lot of global work, a lot of work in Spanish, which is fun. And we've had a #1 gut health product, which is pretty cool. We have a decent sized community too. So yeah, a little bit about me. The Gut Feeling. So the Gut Feeling, the journey with the Gut Feeling, I guess, started about 10 years ago. So I had awful, terrible problems with my gut, to the point where I was so bloated that I literally couldn't fit into my clothes. I often couldn't go to work. I had no idea what was going on, and it took a period of 6 years to really understand what was in fact going on. It was kind of in my gut, it was a gut issue, and to start to get better. And this was a really, really difficult process. I spoke to my doctor, I saw a homeopath, I ate what I can only describe as clay under the care of a gastroenterologist. I had countless blood tests, and it had a real effect on my mental health, which then impacted my physical, gut health. So I ended up in this horrible vicious cycle. But there is a happy end to this story. I now live a symptom-free life 99% of the time, and have done for several years, but got really inspired about gut health along this journey. I think it's absolutely incredible that 70% of our immune system is in our gut. Like, how is that not cool? So despite the fact I had this really demanding consulting job, I decided I really wanted to do something in this space, which is why I started The Gut Feeling, and we launched our first product, which was a gut health subscription product. So within, I think it was about 6 months, we were the #1 gut health subscription product on Google, which is pretty cool. And then in June this year, I decided I was going to quit my full-time job, because I've been running the Gut Feeling on the side. And yeah, that this opportunity was huge. This wasn't just the gut and IBS. This was the gut and Alzheimer's, the gut and cancer, the gut and psoriasis. This was a huge, massive thing that had the opportunity to completely disrupt healthcare as you knew it. So I realized that the subscription box probably wasn't going to cut it. So pivoted to a more kind of data, digital, scalable, impactful solution. We have one of our leading scientific advisors is a leading gut health researcher. His name is Dr. Emran Meir. Thoroughly recommend his books. They're very, very interesting. Had a chat with him, had a chat with our community. It's 4,500 people, and just essentially listened to their journeys with their gut. And the same thing came up time and time again. Something very similar in my own journey was that people didn't understand what was causing their issues, were taking random supplements which didn't necessarily help them, and were ending up in this kind of cycle of vicious cycle, I should say. So we realized that basically, I've got 1 minute left. We realized basically that the way to help was to help people understand what their triggers were. So essentially have built an app which is Clue for gut health. So we empower people with the knowledge of their own bodies to understand what their gut health triggers might be, so that they can eliminate them. So for example, we help you collect various different bits of lifestyle data. You can click into your personalized dashboard of why was I bloated yesterday? Was it the glutinous bagel I ate, or was it the fact that I'm really stressed, I had no sleep, and I've drunk 19 cups of coffee? And the whole idea around this, and the bigger mission, is building this large database, as mentioned before. So how can we use this data in a very careful way with our community to help build more products for this community, this community of people who are completely underserved and misunderstood by traditional healthcare systems in some way or another, and then look to expand into other things like Alzheimer's, etc. Yeah, so that's me.
Brilliant. Thanks so much, Lucy. And I mean, just personally, I love hearing the personal story behind what's got you into doing something. Same thing with Nick earlier, and that's part of what we want to achieve tonight, is just getting that sense of not just what you're working on, but really what's kind of driven you to do something such an amazing piece of work that you're involved in, and wish you all the success. And again, any questions, please post them in the chat, or any thoughts, please do that. Okay, I'm going to hand over now to Andrew from My Eyesight.
Hi there. Hi, thanks for inviting me to this. So I'm Andrew Webster. I'm an eye doctor, work at Moorfields, and have an interest in genetics and ophthalmology. So I'm very lucky in that I run specialist clinics for people with genetic problems affecting their eyes. So I have a career in rare eye disease. And so the reason I'm here is to talk about a project that we've been doing with Loft, Nick and his team, in conjunction with Moorfields and UCL, called My Eyesight. And this is to address two problems that I've certainly seen during my career. The first is that it's hard to do research in rare diseases. It's hard to get enough data together in any one place to do meaningful research. And this contrasts to common diseases that my colleagues look at. And that's a problem. We can never get one institution that has enough data. And the second separate thing is that people see many doctors with rare diseases, many institutions, but the care isn't joined up. The data isn't available to the doctor they're seeing in institution 1 from institution 2. And it occurred to me, and I think meeting Nick, it occurred to Nick similarly, that there's one solution to that, and that is to have an application, a database, or an account of data that the patients themselves own. So bringing power to the patients, having them at the centre of things, so they can get their data now from institutions through GDPR. They can collect together the data. They can consent whether or not they want it to be used for research. And so it would help both problems. And so we embarked on a programme of work, the My Eyesight project, and we're successful in getting funding from HDR UK and Innovate UK. And we're working on that for a couple of years now. And we've had plenty of feedback and input from patients during patient days and questionnaires. And it's been a wholly positive journey. So it's a very popular thing to do from the point of view of patients with rare disorders who want help with research and the doctors that look after them. So that's been very successful. We have a beta platform. Someone's put the study there on the, yes, put the URLs in the chat. And then, I don't know how much time I've got. I could go on forever about My Eyesight. But the challenges we've had after the initial funding, we need more funding to make it sustainable. So we have to think about a business model. Unfortunately, rare disease data is actually valuable. Drug companies need it and will pay a lot of money for it in order to drive their rare disease programs of research, which may, for instance, end up with a gene therapy, which is very remunerative for them. And so we think rather than charging a patient for this account or the hospitals for using it to facilitate consultations, that instead we might be able to make it sustainable by, if patients so want to do so, share their data with pharmaceutical companies to make drugs and treat their disorder, which is ultimately what patients and doctors want. So that's where we are at the moment, and we're looking for further funding to sustain it. The second challenge, finally, before, I don't know how much time I've got. The second challenge is just working with institutions has been hard. So we've been collaborating with both a hospital and an academic institution, and we've found that hospitals are very protective about the data that they generate on patients, and so have been quite defensive about the project. And that's been an interesting journey for us. And that's one reason why this should all be removed out of institutions and should be separate, so that we can grow without needing to have complicated collaborations with hospitals. So that's My Eyesight in a nutshell. I don't know how many minutes that was, but thanks for listening.
Yeah, really, really well summarised. It always, really good point about the sharing of data that gets lost in the system, and I think that's a really interesting challenge that maybe is something that this network can start to, what is it we can do together to start to pose that question. And always remember, Nick talking to me about your particular project, and something that really struck me around rare diseases. Like each rare disease on their own, might have, say, 500,000 people across the whole world that might have that disease. But when you add up the amount of rare diseases there are in this world, there could be hundreds of rare diseases, and hundreds of rare diseases combined by 500,000 each, and actually you could have quite a substantial amount of people that all have their own, who have different rare diseases, but all fit in this category of it. So yeah, this really made me think about how we're all different in different ways, but there's this great way of connecting things. So thanks so much, Andrew. I'm now going to hand over to Murray.
Thanks very much, Will. So I'm a bit of an interloper in that I'm not involved in the sort of healthcare industry, but I have an interest in it, and hence why I'm here. So let me just quickly tell you about myself. So I've got 30 years kind of industrial experience in a whole range of different industries, from automotive to X-ray product inspection for the food and pharmaceutical industry, digital and 3D printing, and telecoms. So I've worked in some quite highly regulated industries, which is, again, a kind of an overlap with what goes on in the healthcare industry. So what exactly do I do? Well, my background is in software and electronics, and I like to think that I bring sort of new and disruptive technologies to market through new product introduction, helping businesses to grow and achieve market share. And also there's a kind of engineering part of me as well, which is using my sort of diverse, very lucky experience in all those industries to really challenge the status quo and find a better way of doing things by creating innovation. So hopefully there's some kind of logical link there to some of the stories and what goes on in this group. But specifically, I suppose, why digital healthcare and why now? So what makes me tick? I like to solve difficult problems, particularly problems which people say cannot be done. I like those ones because I think I can. Not always right, but I like to have a go at it. I like to be in at the early stage of development, where the real key thing is to frame the problem and try and understand what the solution might be. And I think that's where I add a lot of value to businesses in what I do. And ultimately, I want to make a difference to people's lives. So just very briefly, the work I did in the automotive industry has impacted millions of people by the reduction in emissions from vehicles. So that was a personal thing that I actually did. It wasn't on my own, but that's probably the single biggest contribution to global society that I've done. Some other examples: helping startups embrace sort of digital technology, so digital printing. I worked with a lot of companies in China who started out based on the products that we were able to give them, and they created a business from nothing. So not as sort of generous as the conversations I've listened to here about people's personal journeys and dealing with mental health and all that sort of stuff, which absolutely blows me away. I feel very humbled in this group, given my background in engineering. So let me just whiz on a little bit so we can talk tiny little bit about data. But so don't laugh, but from what I can see, there's a huge overlap between what digital health is trying to do for the patient and what I and others try to do for the internal combustion engine. We designed monitoring and diagnostics and control for a car. So just to let you think about this, there are 20 million lines of code in your cars, running your car every day when you get in it. How many lines of code are actually looking after you as a human being? In my case, none. And for me, that sort of underlines why I'm interested in joining this group and sharing my experiences, because I think there's a parallel there. And it'd be fantastic, wouldn't it, in 20 years' time to see 20 million lines of code looking after all of us. And I can see you're all trying to do that. Why now? Well, obviously, digital transformation has been accelerated by COVID. In particular, we don't go and visit our GPs anymore. We have video calls with them. So that's part of the reason behind it. So just in the last little bit, I thought about how can I say something about data that might be relevant to this group. Well, I used to run a competitive intelligence function in a business, and we got lots of data about our competitors. And one of the problems is, how do you know whether that data is true? Sometimes the data is claimed, sometimes the data is validated by yourself, and sometimes it's simply unknown. And what makes me think about the digital healthcare industry, there's lots of data out there. First and foremost, how do you know it's actually valid, and what you can use and what you can't use? And I see lots of stuff to do with AI. AI is driven by data and training. Wrong data in, wrong output. So that's the engineer in me kind of suggesting what I think might be a very big challenge for healthcare going forward. So that's me, and thank you very much for the opportunity to speak.
Yeah, brilliant. Thanks, Murray. And it was great meeting you. And I think one of the successes for this network, or for what we're all trying to do, is getting lots of different perspectives. Actually coming from outside of the health tech, or the health sector is of huge value in itself. Just having someone coming in and I think Einstein's definition of madness is getting the same people in the room and asking the same question and hoping for a different answer. And actually how we get different people who are very skilled at problem solving and applying and thinking, well, has anyone thought of this? And if you've got the same group of people kind of trying to crack the same problems, we might never get there. So I think it's just great that you're interested in applying what you've learned in a sector, health, which is so linked to making a difference to people in this world. So thanks, Murray. Okay, and lastly, last to speak, we've got John.
Hello, everybody. So yes, I'm a founder, but not of a data-based business. I founded a privacy and data protection cybersecurity company just recently, and I'm now working with the Foundry as a community partner. I have 5 free slots a week for you all or around the rest of the network to just grab, just to discuss anything that you think you might have a question about. But the reason I got into it was, for the last 30 years, I've been in IT management as a director of IT, CIO, head of IT, and it's the ultimate generalist job. And in fact, by the end, was I really doing any IT? No, I was doing meetings and staff management and budgets. And so I thought, well, I'd rather specialize, because I'm kind of jealous of all of the specialisms that I manage. And what would that be? And of course, it would have to be something like risks, something like privacy. And that had become a bit of a kind of a bee in my bonnet. I was thinking, the way privacy is being kind of abused around the world right now by our behemoths or Googles and whatnot. So here I am. So I've started that. So I don't really have a current data story, but when I was at the National Theatre, so I have a data loss story. So data being lost to the general public, the kind of thing we all fear. One morning, got an email from marketing saying, hey, weird, just had somebody on Twitter saying that they'd logged into our huge website, ticketing backend, high volume, all that, and they could see somebody else's data. And they'd helpfully posted that on Twitter. So they'd started by going to Twitter to explain that there was a technical problem with the National Theatre's website. And so I had a look at it, and that's what it did look like. And they had contacted both, and they'd said, yes, they had logged in and seen the other person's data. They couldn't do anything with it. And one of them had tried to edit it to change it back to theirs. It was a bit mad. We said, what can we do? Not a lot. An hour later, another event. Same thing. Somebody had logged in as themselves and seen somebody else's data. And so at this point, clearly something is wrong. And we're in the middle of an on sale. Tickets are being sold at phenomenal rate. All the web servers are wrong. And I now have to speak to the CEO and say, yes, we now have a data loss situation, exactly what we don't want, and it's all over Twitter. So I spoke to my team of techs, team of folks that Nick would manage, and said, so what data do we have to explain what's going on? And the answer was, well, millions and millions of lines of logs in hundreds of web servers, all of which takes up gigabyte after gigabyte, and none of which we can even access right now. We'll have to upload it. It'll take hours, and it took the rest of the day just to upload the logs. It's all data, but it's useless. And by the end of the day, I realized that we had a major problem in that we couldn't really say for certain how this was happening, because everybody looked real. All the connections coming in looked genuine. It's just that they were on the wrong. There's a cookie clash situation. And so we spent the night writing new ways of capturing data about everybody that was logging in to our website, data we didn't think we would need. And it made me realize, as coming out of this, that it's one thing having customer data, but developing applications, developing websites actually requires other kind of data, operational data about how the website is working and about how people are moving through the website. And we wrote a series of kind of ways of trying to dump data as people logged in, capturing things like, well, like even their screen size. Could we differentiate between two people with different IP addresses but the same session based on things like that? It took us months. 2 months. And the second sort of point that I took away, and I still have now as a core foundation of what privacy looks like, is data minimization. And after the second day, we realized that we could either take the website down, but now we would never find these bugs because we couldn't find any way of replicating them, or we could just carry on and accept that occasionally this was going to happen. And the reason we decided that is, one, we could just eliminate all the super private data. So we got rid of phone numbers and family and sort of your children's names, got rid of all that so that when you logged in, you could just see your name and address. That's almost public data via the electoral register. And that secondly, it was happening at such a smaller number, a few a day. And thirdly, you couldn't actually get a ticket from somebody else's credit card. All you could do is buy somebody else a ticket, right? You could use your credit card to buy somebody else a nice ticket. So that made that the harm to individuals was relatively low, right? And that we had minimized the actual data that was released. And so we went ahead and it ran like this for several months until we finally figured out the technical solution and replicated it, and that was that. But that was my kind of takeaway, was the minimization thing. The harm thing means that even if your website has issues, you can perhaps continue to operate because you've reduced the harm to individuals. So that's my story, my data story.
Brilliant. Thanks, John. And thanks to all the speakers. I think what was really nice, we had a real nice mix of founders who are in the midst of it and wrestling with data as part of, and in really different ways as well, to Murray, who's interested in applying data from another sector into how it, and his experience of working with data into the health sector. And then John, in terms of your own experience and interest, it's great just to have such a variety of different ways in which we can all contribute to this. We're now going to go into Q&A. I know there's a question for you, Andrew, in the chat. And before we do that, I'm just going to ask everyone if we're going to launch a quick poll for our next event. We've got 3 different topics that Helen has put together that might be of interest for our next event, which will be in person on the 10th of March. We'll share details of that a bit later on, but hopefully everyone will be able to see the poll, and if you can participate in that, that'd be great, and just fill in whichever one you think is the most interesting to you, and we will have that as the topic for our next meeting. Whilst that's going on, Andrew, I don't know if you saw the question from Dips in the chat, and whether you've got any thoughts on his question, or if you'd like me to read it out.
No, that we can read this out. I'm trying to sort this questionnaire out.
Have I distracted you by putting both on at the same time?
I can't multitask, William.
Okay, let me read the question just so that everyone can see it. So, great to hear your story. With respect to the joined up care for clinical encounters, should the project continue to grow, do you plan for this data to start moving into future shared care records? And then additionally, I've worked with companies who have considered allowing patients to benefit from their data in a monetary format for sharing with pharma. What are your thoughts on this?
Yeah, so Dips, thanks for that. Two very good points. So, and shared care is growing. So by that, when we talk about shared care, at least in rare disease, we often talk about the specialist centre, which is often a long way away from the patient, and their local hospital. And we're not doing enough of that, and it's not joined up at all. And so a site like My Eyesight, or some patient-centric site for data, would facilitate sharing the care between the specialist centre that they access rarely and the local centre that they would access more for their ongoing care. So that's not possible in the NHS at the moment, at least in ophthalmology. And the second point is very important. So having money coming in, it would be great to share that with the people who have the rare disease. That's only fair. That seems to be a fair way to go. Many of us are worried that data's being sold anonymously to companies and Google and things without any awareness of the patient. and with rare disease patients, then really I think they should benefit from the fact that their data is peculiarly valuable. So that would be a wonderful thing to do, and it would have the benefit of incentivizing patients as well, incentivizing busy folks with a disorder to maintain their record well is important. And so to have something come back to them would be perfect. So thanks for that. They're two very good points. What's your background, Dips? Sorry.
Yeah, I wasn't sure if I was allowed to speak.
Yeah, go for it. Yeah.
I guess I'm a GP by background, but I've worked in health technology and building apps and doing app design and interoperability. And I think the first question is really, and I know it's a long way off, but the shared care record is moving, slowly, and it is getting there. Lots of different integrated care systems are starting to get all their interoperability and standards together slowly, and things like SNOMED are becoming across the whole of the health sector, and there's a plan, I think, in the future as well for sort of genetics databases as well, to have certain codes that sit in things like SNOMED as an international terminology. So it was more for the future, just to think that as all these different apps and things grow, and some of them will be very much embedded at patient care in tertiary or secondary care centres, just when will this all come together and how will it look? It will be really interesting. And then the second question, yeah, good answer. I think it's a really interesting one. I've worked with a few companies on this, and there's no right answer to it, really. It was really just what your thoughts were. There was definitely a feeling that patients should benefit from their data. It's their data. But then there's that sort of balance between, well, maybe not so much for rare diseases, because they clearly have a rare disease, but if patients knew that their data could be sold or they could benefit from it, how would that actually impact the quality of that data if they knew there was a monetary benefit for it as well? Clearly it could make it a lot better, but there could also be other things that could happen, or things that patients might decide to do because they felt that might increase the value of the data. Unlikely, and it's a little bit out there 5-10 years in the future, but I do think in about 10-15 years time, maybe sooner, that's the sort of stuff that will be happening. I think patients will expect to benefit from their own data, whether it's anonymized or not, if they're the source. But I think that's where people will go, but a bit controversial maybe.
No, I like that. Yes, it might be hard we just have to manage what patients do, and that people don't cheat the system, of course, but that's the one drawback of that. But it's extremely fair way to do it, and it would have the benefit of incentivization for the patient. And joining people up in the NHS, you'll know as well as me, and joining people up within research is just hard. I've failed many times. I've sat on many projects to try and share data with colleagues on rare disease patients in Manchester, Birmingham, the States, Europe, and they've failed because it's just so hard to do something on behalf of the patient. Whereas if you put them at the centre, a lot of the problems fall away straight away. And so that's what would be the main advantage of having a patient-centric platform such as something like My Eyesight, I think. Thanks.
Great. I've got a really interesting question that follows on from this, question for Lucy, around the crowdsourcing of data and whether the gut feeling is intending to crowdsource its data. What's your thoughts, Lucy?
Oh, there's two of me now. I'm just going to turn this one away. It's very disconcerting. Essentially, the way that I see the gut feeling, we're very inspired by the things that Clue are doing, in the sense, and something I think it was Dips that mentioned earlier, in the sense that this data has to be helpful for people. Like, we are building this database, but ultimately, like, the data that we're collecting needs to also have value for the people who are inputting their data. So, for example, like we want to help people understand what their gut health triggers are. So as whether we're crowdsourcing the data, it sounds almost like we're just asking people to donate their data. Like, that's very much not what I see what we're doing. We are providing a service for people who are suffering or struggling with various different symptoms, and helping them understand more about gut health so that they can reduce or eliminate those symptoms. And then as a part of that, we are helping to build more products and services for these people who are struggling. So I don't like the word crowdsource because it sounds like those people are donating, and I don't feel like it's that, because it's in exchange for a service, if that makes sense.
Yes, it was more like not so much donating as exchanging. So are you saying that people would see how many other people had a series of criteria, so this problem and perhaps these solutions or these symptoms or these triggers?
Yeah, I think so. I think there's a couple of menopause apps that do this really well, which talk about like sharing stories within their community of how, I don't know, people with who are having sleepless nights also are suffering from XYZ and they find this helpful. I think obviously with a like degree of scientific rigor going into that, I think that's actually something that could be really helpful. But as to whether we'll share like a panel of data and insights to these people, I don't think the average person will find that helpful. So it's just how do we use that information and communicate that information in a helpful, digestible way.
And I think with particularly with let's say communities of people who are quite underserved by conventional health systems, I actually have a similar problem to what you described, so I can identify quite well. You do get quite desperate, and I think there's quite a strong incentive for you to do something which, you know, if enough people like you do collectively will be beneficial, because it, you know, a lot of these things like rare disease obviously is particularly, rare diseases are particularly serious because many of the rare diseases are fatal in childhood, so people are very strongly incentivized, but also chronic conditions that people live with, I think they're very incentivized to donate their data, because there aren't necessarily solutions out there that they can access in any other way. So I think there's quite a strong incentive there, and it doesn't necessarily have to be monetary, I think.
Yeah, I agree. And like, you know, I think if you've had this problem and you've had a similar problem, like you'll know that like times get desperate. Like I bought 2 different notepads, one to track my mental health and one to track physical symptoms, and I think another for like diet. And I did this like every day, twice a day, because I was so determined not to have my gut rule my life, and rule like relationships, health, every part of my life was completely affected by my gut. So I can't agree with that enough. I think it literally does take over your life and you'll do anything to get better.
Can I just ask another, maybe just slightly to the side, but as I was saying earlier, a lot of what we do when we collect our evaluation data is qualitative, but we do ask for explicit consent, and in particular from the doctors and nurses who participated in our long COVID programme, for their consent to be part of a study or to be interviewed, and we don't really do anything with that or them to follow up, other than, you know, keep their details, update them about other groups. Is there something that they could add value to? Because I know that they want to participate. I mean, we're talking maybe 100, but is there something in that context that maybe that we should know about? Just asking that question.
That a question to me? I don't think that was.
There's a general question.
Yeah, general question, yeah.
Maybe Nick or Helen on the spot with that one. And what's your thoughts, Nick?
I wasn't sure, Murray, whether your question was whether you have an obligation to do something with it, sort of legally or compliance, or whether you meant sort of creatively in terms of technology. Is there something you can do? I mean, my experience is that once you create the opportunity for people to collaborate with data, suddenly really exciting things happen. And that was one of the interesting things on my eyesight project. That data is intensely personal and private, but it doesn't. But what I learned working with Andrew is that people with rare disease really want to find other people with the same rare disease, and they will go to extraordinary lengths to find the other people around the world and to create communities and to work together, often led by, you know, a couple of champions and highly motivated individuals, to actually prepare the data as a community and try and persuade pharma companies to research into their condition. And I think that perhaps lines up with some of the other stories we heard. Once people have a health condition, they're really motivated to do something about it, and often seeking out others who have a shared story as a way of doing that. So I wonder if there's something there that could evolve your model. I don't know, just a thought, starting at 10, but yeah.
Nick, I might add to that, because as someone that's not particularly data orientated myself, but very passionate about networks and kind of movement building, and that I think what was resonating with what Lucy was describing, what you're describing, with that sense of belonging and connection to either a disease or a group of people who share something in common. I think what I was gaining from what you said there, Murray, is you've got a group of people who've been on your programs, who've benefited from, you know, the support that you've given them around their mental health and well-being as a healthcare professional, and they've put themselves forward as willing to participate or take part in something further, not knowing exactly what that might be, but in some ways they put a little message out there saying, I'm interested and I'm keen, I maybe am that champion or willing to be part of the next phases. So in some ways that there may be a way to, depending on how you've asked the question, to connect with those 100 people and say, would you be interested in working with doctors in distress to, you know, to help us develop our, you know, what you do next, or to champion your work? You know, it'll be really interesting to see, you know, it's almost like potentially an invitation to a group of people who are quite, you know, motivated and willing to give back to the community. So that's how I interpreted it. I'm not sure whether we've got the question.
Yeah, no, absolutely. No, that's absolutely. And I mean, we've had support with, you know, branding from the same groups of participants and different ideas around how we get our message out. But really, I want to know how we can support them with whatever it is that ails them, to, you know, on whether it's studies or anything like that. So yeah, absolutely. Thank you.
I was just going to say, we've got just over 5 minutes left. We're doing very well with time, and I'm really enjoying this conversation. Just maybe time for another question, or if Helen or Nick, you know, just have any sort of summary thoughts from the discussions, or any questions that you had, you know, from any of the talks.
Well, I mean, just building on what you said, Will, I just had another thought on that, and it's about, like, kind of how does data connect with communities? Because actually, you know, data flows through communities. They're really closely connected. Often clients say to me, you know, Nick, how can we build our user base? Or how can we have more users? Or how can we reach a critical mass that we need to achieve in order to be financially viable? That's a really common question for a client. And so we're always looking to try and build a system or an application, a platform for them that is going to grow like that. And there are two levers that are really useful to know about. One is that if you build your system such that every time someone adds a bit of information to it, it becomes more useful to them, then you create a really positive feedback loop. And then you can really redouble. If you then build a system such that every time they get someone else involved in it, it becomes more valuable to them, then people are really motivated to get their friends involved. So those are the sort of underlying mechanics for how do you build a platform that can scale up and grow and sort of become viable, reach that critical mass. So data and communities, it's all about, I mean, you know, using apps, about putting in data, isn't it? And transactions and exchanging stuff. So, yeah.
Great. Helen, did you have any sort of?
Yeah, and it's just a sort of a general observation, a thought. I don't have a solution, but just to sort of put it out there that, and we've discussed this at previous events as well, that there's a lot of data silos in healthcare. I mean, to me, that's one of the biggest problems, is that there's loads of data, but most of it isn't usable because it's locked away. And a lot of what we've talked about actually is almost sort of, the data effectively is either in the NHS or it's out of the NHS. And it's a shame that there's no way to sort of link those up. So, you know, for example, you'll be gathering lots of brilliant kind of data about gut health, but it would be really brilliant if that could be augmented by sort of clinical data that's collected, because a lot of the people using the app will be sort of being kind of seen by people, doctors, either within the NHS or privately. And it's just an observation that always seems a shame to me that so much of it is siloed. And I think it's unfortunate the way our kind of health system is structured drives that to happen. And I think it's so difficult to manage to work with, like, integrate data into the NHS. And it's sort of it's like the NHS is just loads of little data silos, but doesn't really talk to the outside world much, or talk to people about their data that they are collecting themselves. And it just seems a shame. It's just an observation. I don't have a solution, but I guess it's just something to think about.
So we're just coming towards the end, but we've got a couple of hands raised, and Lucy's going to just jump in with a quick thing. I think, so is it Lucy, then Dips, and then Andrew, and then we'll draw it to a close.
I think that's such a valid point, and I think one of the features that has been most requested during our beta test is people who are using our tool to collect data and understand more about their gut issues want to be able to export that data and take that to a healthcare professional. And we want to make that easier so that we can send them to their GP. They've got the 4 questions they need to ask. They've got this log of the data they've been collecting about themselves, then make that process so much quicker to be like, right, the GP's like, okay, yes, you need to go and see a dietitian. The wait list is huge, but actually you could go to XYZ. I don't know, whatever it is, but like that export thing, I completely agree. Like that needs to also be an accelerator into the healthcare system that actually they may need to support them.
Yeah, really interesting now because we've got Dips and Andrew, both clinicians working in the NHS. Dips, do you want to go first?
I'll be really, I guess just 2 bits from what I've learned working with platforms, and I'm a clinician, so I might be wrong here, Nick, but as our platform grew and our data just grew, one of the things that we didn't realize was how you structure the data, or how the people that build these databases structure the data, stuff that I don't understand, has a massive impact on when you want to analyze it, especially if you want to analyze millions of things in one go, or thousands of bits of information in one go. So wherever you guys are on your journey, I mean, you may not need to worry about it now, but if you start growing and you start having huge amounts of data, the way that it's structured will have an impact on how you can run analytics on it without slowing everything down. And the second piece is if you can use standards, you may not be able to for things that are patient facing, but prescriptive standards, it can help. That doesn't mean that people will pick the right thing, you know, to describe their condition. That still needs to be worked on. The understanding of it needs to be worked on, but it puts you at a head start for when you want to share that data. It won't solve it completely, but they were just things that I've learned, which I wish I'd learned earlier.
Brilliant. Thanks so much for sharing that, Dips. Andrew, last point, and then I'll hand over to Helen.
Oh, sorry. This was just a small point about networking and allowing patients to network. Just a quick anecdote. We discovered 2 families at Moorfields to have a very rare disorder that we didn't know they had before, and wrote to tell them. And then there was a delay before we met them online to talk more about it. When we did meet the 2 families online, 1, they knew each other. 2, they joined a Facebook page and they knew more about the disorder than is written in the literature. They'd gathered information from the few people around the world that have it, that I learned from them. And there are these specific symptoms that recur in this particular disorder. And the reason they could do that is that the disorder has a unique acronym. So they're able to search on Facebook and find other people with it. And so that would work for the gut feeling, you know, people getting together, explaining this is a great idea. You learn more from people aggregating their symptoms and together. So that's one way it works.
Yeah, and no better tapping into people who are just have that passion and that connection to the issue, become incredible resources to that, and will go to lengths and be creative, and will find ways in which to get to an answer that you might not think is possible. And I think that's been something interesting about all the discussions tonight. There's so many different people that can contribute to your idea or a challenge from so many different perspectives, whether it's from the patient perspective, or tapping into personal motivation, tapping into someone from a different sector, someone who's an advisor, you know, probably learning, you know, from different founders, people running different projects, and learning from their experience, or from clinicians who've been through it, who've been at the end of it and not being able to use the data once it's been done. So I think that for me is a lot of why we, you know, have brought together this network, and I've really enjoyed the conversation. So thank you to all our speakers. I'm going to hand over to Helen now to wrap up. I think hopefully, Helen, you've seen the result of the poll as well. Yes. Let everyone know what when the next event is as well. Thank you.
Great, thanks, Will. So thanks everyone for coming. We've got another event scheduled for 10th of March. Hopefully, things seem to be moving in the right direction, that we will be back in the Health Foundry in person. We're also hoping to stream this next one online. So anyone who's not in London or not able to get to London, if you would like to join that way, that would be great. So the most popular topic is 5 design considerations for a digital health MVP. So Nick and I will be talking about that. Loft have got a lot of experience in helping startups and other clients design an MVP, and my background is in designing digital health systems. So hopefully that will be a really interesting topic. So please sign up for tickets. I think Natalie's put the link in there. And also, if you'd like to reach out anytime to Loft for a chat, I've put my email address in there.
Brilliant. Thanks very much, everyone. And we look forward to seeing you at the next event.
Thank you very much. It's really nice to see you.
Thank you.
Thanks, everyone.